We'll be talking on how to ensure 100% success in a disc surgery. Now, why is this important? Why is this important? Well, basically, it's amongst the most common surgery that is done by spine surgeons. It's a bread and butter. The incidence is 5 to 20,000 adult annually. Symptomatic in 1 to 3% of patients, and if not done correctly, the recurrence rate can go as high as 21% in some studies. So how to ensure success? Well, basically you should not miss any of these steps. You should follow a good protocol, starting from a good clinical examination, going through the imaging in hand adequately, then doing a good pre-operative planning, a proper execution of the plan intra-op, and sticking to good post-operative protocols. Clinical exam ideally should be done by the surgeon himself. Even if you have got residents and fellows, try going to the theatre before the surgery and just check the patient once. Do a neurological level if there is any deficit to confirm the levels. You should pre-operatively document VAS and ODI scores to measure outcomes and have a good clinico-radiological correlation. If there is anything mismatched, you should think deeper before going into and operating. A clinical exam, make sure that you use all those special tests like SLR, cross SLR, and presence of a list to confirm your radiological diagnosis. Get adequate imaging done. Sometimes dynamic X-ray is missed. That will help elicit any subtle instability which has been missed on a clinical exam or on an MRI. It also helps you, if you read your X-rays well, it will help prevent disasters like missed level surgeries, and it can make you aware of things like sacralization. People who are in favor of doing endoscopic surgery, a study of the level of iliac crest is important in order to determine if you can do a transforaminal approach or you have to go by an interlaminar approach. This especially when you are tackling the L5S1 disc. Make sure that you have recent and good quality MRI with you. Now usually a 6-month-old MRI is fine, but I usually prefer in a disc surgery an MRI should be not older than 3 months, or if there is a significant change in symptoms, please do an MRI before going back inside. That will also give you an idea of how much fragment you should expect in intra-op, because sometimes acutely they present with large extruded disc, but at the time of surgery part of it has already been resorbed, so you'll undergo a treasure hunt syndrome. Once that is done, you do a correct pre-operative planning. Now technically you can use whichever approach you like. There are different ways to skin a cat. You can do an endoscopic approach, or you can do a classical microdiscectomy or open surgery, or a tubular approach. So depending upon what works in your hand, you should pick that approach. And sometimes there is some diagnostic dilemma. Let's say there's an old patient with multi-level stenosis with an acute disc and you want to tackle it endoscopically. Then don't shy away using diagnostic blocks to confirm the level of surgery. Intra-op, make sure that you do not miss levels. You cannot miss levels in spine surgery because that is something you cannot forgive. Confirmation of level should be done before start of surgery and before entering the disc space. You could use different techniques. Some people use skin markers, some people use needles in the spinous process, or just confirming where your retractors are. But make sure that you don't miss a level. Eventually you should decompress adequately. So you decide your endpoint of decompression and stick to it. So in case of an endoscopic surgery, a good visualization of the nerve root and good mobilization along with pulsation has been considered to be an adequate sign of decompression. When you're doing a microdiscectomy or a tubular discectomy, medial retractability of the root determines if you have had adequate discectomy. Then everyone has a different post-operative protocol. Some mobilize the same day, some mobilize next day. Just make sure that your mobilization protocol is adequate. Your physiotherapists know what you have to do. If you are a brace user, make sure that the braces are there before the mobilization. So if you stick to all of these things, you almost always will have a good result in this surgery. Thank you very much for a patient hearing.